You know, we need to separate issues that NHIF was providing the financing bit. The facility is responsible for giving you the service. So now they cannot turn around and say we cannot, we are unable to give you proper service because of NHIF. We are shifting the thinking because one, NHIF is not meant to be competing private insurance. It is not. At the moment, that is what is happening because of these enhanced schemes. So we are focusing it and saying, can you concentrate on the hustlers? Can you concentrate on the bottom of the pyramid of this country? Anybody who is down here. So we want to have a national social security scheme in terms of healthcare, that everybody down here is taken care of. You and I, if we can afford private insurance, then we pay for it and get all the goodies that may come with private insurance. And that means you can access whatever private facility you want to use. But what we are doing at NHIF is that we have a basic package so that if you walk into a public health facility, you get services. With that basic package, if you even walk to the nearest private facility, you should be able to get service with that basic. If you walk to a faith-based facility near you, you should be able to get what? Service. Yeah. So we want to move away from competing the private insurances. Let them do what they are good at doing, and we refocus NHIF to meet the needs of every common Kenyan. One, maybe just to realign that, it's not that we are moving from KEMSA to NHIF. No. In this universal health coverage, we need both institutions. KEMSA is a key in terms of ensuring that we have health commodity security, that the commodities and the products that are required in terms of driving healthcare are available. NHIF is another strong pillar in this universal health coverage because it deals with the financing bit of it, that the monies are available to Kenyans to be able to take care of their health. So specifically, we are doing a lot of reforms at NHIF. You know, previously it has been registration, and it has been taking care of individuals. So one of the biggest shifts that we are going to do is that now we are taking care of, we are planning to and moving towards household. That instead of covering an individual, where, you know, if you are employed, a cage, if you are married, your husband is also employed, you both contribute. But in terms of the benefit, it is one. So now we are pulling together and saying, your contribution for you and your spouse is a household. So one contribution is enough to take care of the whole household. The other major shift that we are going to do at NHIF is that we have concentrated on schemes, the enhanced schemes, the super covers that you hear about. We have forgotten about the basics. So we are structuring NHIF to be able to cover the bottom of the pyramid. That anybody walking into a health facility, then they are able to access treatment. So that is how we want to refocus NHIF. Previously it was, and it works mostly for people who are employed because there is a check-off. Then we have the informal sector that contribute, I think, is 500 shillings per month. But being informal, then in terms of just ensuring that they all pay up is a little bit difficult. So now we are saying we want to put together something and have something like an essential package for all Kenyans, so that irregardless, then you are able to access healthcare at the facility most nearest to you. What do I mean by that? Is that now we are going to focus more on primary healthcare. We focus on preventive, we focus on promotive, and we focus on rehabilitative. Yeah. So we want to see how we reorganize the finances at NHIF. Currently, we have had several projects running on NHIF. We have the indigents, that is the most poor who are enlisted. We have a scheme for the school-going kids called Edu Afia. We have a scheme for the old called HISP for the elderly. We have another scheme, Linda Mama. So now we are saying we want to have a scheme that covers everyone. That a pregnant mother, your needs are taken care of. If your child is sick from the same household, their needs are taken care of. An elderly in the same household, their needs are taken care of. That is how we are shifting the thinking in NHIF. I don't know what is the measure in terms of saying that this is a tough ministry. So maybe you will enlighten me on what measure you're using. However, I'm cognizant of the sensitivity of this ministry, that it is a matter of life and death, and that it touches on each and every Kenyan, matters of health, and you cannot compare it to other ministries that would be dealing in other things that may not concern everyone. However, this ministry concerns every Kenyan. Being aware of that fact, then I am clear of what it is that we need to deliver. Our president, on his campaign trail, together with the team, they made a promise to Kenyans on what they are going to do in the health sector. And basically they promised that they will be able to give Kenyans universal health coverage. So I am clear that that is my target, that is my focus, that I am working on to deliver that to Kenyans. And if you may recall, as I said in my vetting process, many maybe are expecting that universal health coverage is an event, that one day it will be bang, universal health coverage. But however, it is a process. So we are putting in place measures and laying out the strategies to be able to achieve that universal health coverage. And in the promise to Kenyans, I'm sure by now you are familiar with what we are calling the plan, the Kenya Kwanza plan. One of the things that we promise in achieving of this universal health coverage is affordability of commodities. And that is purely the responsibility of KEMSA. Procuring, storage, warehousing, and distribution. We are rethinking on what strategy to use in terms of procurement. And our thinking is towards being able to meet the basic minimum that is required of us in matters of healthcare. So we are developing an essential package. The team, in fact, we've had people are waiting for me. There's a team that is working on an essential package. Then we shall put together resources. We shall put together different expertise, people with a different experience in procuring, so that we have the faith-based, we have the private and the public working together in terms of procurement. So then we achieve economies of scale and be able now to distribute through KEMSA. By so doing, we hope that then we are able to bring down the costs. You know, in procurement, once you consolidate and the quantities are big, you buy at less. If you go to Gikomba today, if you're buying one dress, you'll buy it expensive, as opposed to somebody who is picking what? A bale of clothes. So we are saying we want to have some form of strategy, a plan, maybe a board, if possible, that sits together and says, what is our national requirement in terms of paracetamol tablets for pain? So the people in the private sector will say, for us, we need 1 million. The people in faith-based facilities will say we need 2 million. The public will say we need 5 million.